Hi, everyone, and welcome. I'm Liz Whitehead, Managing Editor with U.S. News Live Events at U.S. News and World Report. Today, we're examining battling health disparities in treating chronic kidney disease, a condition that affects more than 1 in 7 adults in the U.S. and takes a disproportionate toll on people of color. Our expert panel will explore some of the most promising efforts underway to improve access to the most effective kidney care for all. Today's webinar was developed with support from the American Kidney Fund. I encourage you to visit usnews.com/events for more information on our speakers, along with links to future events and videos from previous sessions. Today's program is also being recorded and will be available on demand at usnews.com. During the live discussion, we may have time to take some audience questions, so we invite you to type them into the Q&A in Zoom. Our team will review these and try to incorporate them later in the hour. Now, I'd like to introduce our panel. LaVarn Burton, President and Chief Executive Officer of the American Kidney Fund. Dr. Lilia Cervantes, Director of Immigrant Health and Associate Professor in the Department of Medicine at the University of Colorado Ann Schucz Medical Campus. Dr. Deidre Cruz, a Professor of Medicine in the Division of Nephrology at the Johns Hopkins University School of Medicine. She also holds appointments with the Hopkins Schools of Public Health and Nursing, the Welsh Center for Prevention, Epidemiology, and Clinical Research, the Center on Aging and Health, and the Center for Health Equity, where she's Deputy Director. And Dr. Elaine Koo, Associate Professor in the Departments of Medicine, Pediatrics, and Epidemiology and Biostatistics at the University of California, San Francisco. Welcome to you all, and thanks for being with us today. Now I'll turn it over to Michael Morella, Managing Editor at U.S. News, to lead our discussion. Michael?
Thank you so much, Liz. Thanks for our panel for joining us, for our audience for being here, and let's get right to it. So we just heard a little bit about your titles, your organizations, but I'd love it if you could each briefly describe a little bit more about your roles and in particular your work in addressing health disparities in treating chronic kidney disease and beyond. Dr. Cruz, could we start with you?
Well, sure. First, thanks so much for bringing us together. I'm really excited about the discussion today. So as said, I'm Deidre Cruz, and I'm a nephrologist at Johns Hopkins. And the focus of my work from a research standpoint is on addressing some of the key social drivers that kind of underpin the profound disparities that we see in kidney disease, particularly when we think about racial and ethnic disparities, as well as socioeconomic disparities. And I have a particular interest in things like how access to healthy foods and safe places to live play a role in those disparities.
Dr. Elaine Koo, how about yourself?
Hi, everyone. Thanks so much for having me. It's an honor to be here, and I'm excited about discussions. So I am a pediatric and adult nephrologist. I primarily see patients in the clinic who often transition from pediatric to adult healthcare systems. My research interest has really been in health disparities in chronic kidney disease, as well as transitions between different phases of kidney disease. So a lot of my work has been on access to kidney transplantation for patients who are on dialysis or have chronic kidney disease. And in particular, I often conduct research examining how different policies and approaches to care in children and adults differ, and how that really associates with differential outcomes, with a focus really on racial and sex disparities. Thank you for having me here.
LaVarn Burton, how about yourself?
Thank you so much, Michael, and I really appreciate your focusing on this issue. That's so important to all of us, and I look forward to the discussions with the rest of the panelists. As CEO of the American Kidney Fund, my role is really in serving the 37 million Americans who have some stage of kidney disease, many of whom do not even know it. But at the American Kidney Fund, we cover the gamut from early detection and prevention focus and programs to treatment and disease management, including transplantation, as well as support for research and advocacy, very importantly, on behalf of patients who have kidney disease or who are at risk. Because kidney disease disproportionately affects people of color, that is, equity has always been an issue for us, and trying to make sure that everybody affected by kidney disease has access to the best care that they can get. But in the last several years, we have developed a specific initiative that I'll talk more about later, really focusing on 4 areas of kidney disease disparity. And we want to do our role in trying to close those. They have to do with early detection and prevention, with the gaps in the use of home dialysis care, as well as transplantation, and the participation of people of color in clinical trials. It's very important that as new therapies are developed, that they are appropriate and effective for all of those dealing with kidney disease, and especially for those populations that are most disproportionately affected. So I look forward to the discussion. Thank you for having all of us.
Forward to it as well. Dr. Lilia Cervantes.
Hi, everyone. Lily here in Colorado. So if you're Midwest, good morning. I'm really excited to join this panel and really glad that you're highlighting this issue, which is so important. My area of research is really focused on disparities, assessing social challenges. As Director of Immigrant Health, I often partner with community and consider access to care issues as well as community-based type interventions to improve disparities among patients with kidney disease. And so that's really where my focus area is. As a clinician, I'm an internal medicine hospitalist, and so I see patients that are hospitalized. Thank you.
Thank you all. And I want to come back to a number of the issues that you teed up for us. But before we do that, I'd love to start, we heard a little bit about the prevalence of chronic kidney disease. I'd love to understand briefly how the COVID-19 pandemic has impacted CKD and where we are at this particular moment moving forward in 2023. I know the World Health Organization changed its assessment of the pandemic just last week. So could we talk a little bit about that and unpack the last couple of years, but also where we are moving forward? LaVarn, maybe you could start us off here.
Yes, I'd very much like to. When the pandemic first struck in 2020, we knew immediately it was really a freeze moment for the American Kidney Fund, because we knew that while any number of us across the country and across the world were going into isolation until we better understood what was going on, we knew that people with kidney disease, especially those who are in kidney failure and who've had transplants, could not do that in the way that many of us could, because they had to go for dialysis care or they had to go for other medical care. We know that their incomes are compromised, and so very largely they also have to take public transportation in order to get there. And then to the extent that all of us had some isolation, they were alone dealing with this disease, which is such a heavy one. So, that was I think the psychological effect, as well as the real challenge in terms of trying to be safe and to still make your medical appointments. Those were the immediate things that hit us. But we also know now that in terms of the actual incidence of the disease and the adverse outcomes, the most negative outcomes, meaning death, that they were disproportionately suffered among people who had chronic kidney disease and kidney failure. If you look at Medicare population, for example, in the first year of the disease, people who were in kidney failure, who had a disproportionate, a greater impact. There were more of those people proportionally who contracted COVID than any other Medicare population. And we also know that death rates were very high among that population, that people in kidney failure, that actually a full quarter of them died within 90 days. We know that you add to that the impact of this disease of COVID on people of color, that there was a disproportionate impact there. So if you can kind of sandwich those things, that if you've got kidney failure, you're disproportionately affected. You're more likely to get COVID, and then more likely to die for COVID. And then add to that, if you are a person of color, African American or Hispanic in particular, that you were more likely to get COVID and more likely to die. So if you were a patient who had kidney failure and you were a patient of color, it was devastating in terms of the impact that COVID has had on people.
Could I also add a comment to
Please.
that? Yeah, so just wanted to also just perhaps underline some of the comments, but and say that in addition to the effects of the COVID pandemic on the for people already with, particularly people already with kidney failure, I think what we are learning as well is that it was such a risk factor, or is such a risk factor for developing acute kidney injury. And there is anticipation that we are going to be seeing people in the years to come who develop chronic kidney disease that is actually related to or as a consequence of having experienced COVID infection. So thinking of people who have what is sort of commonly referred to as long COVID being included among that. And so I think we will be learning for years to come about the impact of the pandemic. I think clinically, and for sure there have been economic impacts as well. As I alluded to, a lot of my work is focused on social risk factors for these for poor kidney health. And we know that even separate from the sort of biological and kind of clinical impacts of COVID infection, there have been so many economic effects due to the mitigation efforts around the pandemic that we will likely continue to see those showing up in impacting people's kidney health for years to come.
Elaine or Lily, anything you all would add from your perspective?
I would add that I agree with all the comments that have been said so far. I would add that I think with the COVID-19 pandemic, not specific to kidney disease, but certainly we've seen the use of telemedicine really being adopted. And whether or not that will lead to disparities or inequities in care, I think still needs to be examined, particularly in those who may have lower access to health technology or digital devices that allow them to connect, and how that impacts care and laboratory testing and follow-up, I think are all other repercussions of the pandemic that we still have yet to, I think, fully grasp its effects.
Yeah, and if I may add, at least in Colorado, what we've seen is a doubling of the number of undocumented U.S. residents with kidney failure. And this is just from these last 3 years. The Latino population is about 30% in our state, and they have a very high prevalence of diabetes and obesity. And so they were already at risk for kidney injury going into the pandemic. But one positive, I think, lasting effect from the COVID-19 pandemic has been the increased use of community health workers. Going into the pandemic, there are, across the country, I think there's a lot of mistrust, misinformation, discrimination that I think only became, created more anxiety as COVID-19 was coming to the country, because we realized that we really needed to connect with these communities that were at risk because of the social challenges that they face. And during the pandemic, it seems that many states made community health worker interventions possible and very quickly. And what I've seen this past year is that many are trying to identify ways to make these community health worker type interventions or programs more sustainable. And so some states are passing legislation, some states are trying to find ways to see how Medicaid can provide reimbursement. And so it's been, great to see sort of an increase in a more culturally diverse workforce that connects with community in different ways because they are culturally congruent and language congruent. So, yeah.
So again, just building on some of what you all have shared, what are some of the specific efforts that your organizations or that are happening in your communities are doing to address health disparities, again, related to CKD, but also to some of the broader social determinants of health? Deidre, maybe we could start with you, but I welcome perspective from anyone.
Sure. So I'm at Johns Hopkins, as was mentioned, serve as Deputy Director of our Center for Health Equity, where we certainly are a research center that has done a lot of work around documenting a number of the health inequities that exist across a number of different conditions. But I think we probably pride ourselves most on our focus on testing ways to actually mitigate and even ideally eliminate some of those those inequities. And so when it comes to kidney disease in particular, we recently, for example, wrapped up a study, a clinical trial where we were partnering with a local grocer to provide healthy foods to Black adults who have both high blood pressure and early kidney disease, and saw some favorable results in terms of some markers of kidney disease improving in those individuals that were a part of the group in the study, where they received both the healthy food as well as coaching around eating a more healthy diet. And the study was particularly focused on people who may have limited access to these types of healthy foods due to disinvestment in the communities that they live in. And so that's one approach. In other ways, we've, as Lily mentioned, we have also been pretty engaged in studies where we've worked with community health workers to provide to connect participants in our research studies to resources in their community that might actually help to lower their risk of some of the poor health effects of conditions like hypertension and diabetes, as well as kidney disease. And so those are some of the things that we're excited about, particularly where we see opportunities to then scale what we're finding in those interventions to either broader health systems, but also with implications for both health policy as well as public policy. So for example, in the case of the food, our sort of study focused on healthy foods that may have some public policy implications. So those are some of the ways that we're trying to kind of move things forward with respect to health equity.
Michael, if I might add to that, at the American Kidney Fund, there are a number of things we're doing. We started a health equity coalition because we think in order to, there's so many different aspects of this, as Deidre just outlined, that we've got to bring together many different groups to really take a look and figure out how we can work together from our different perspectives to reach those who are most at risk, to provide them with some essential tools, including information and education, and to also connect them with the healthcare system in a meaningful way and in an informed way so that they can be as prepared as possible to deal with the disease, to understand the importance of food, the importance of following the treatment regimen, that they are identified early. Because one of the great positives about kidney disease is that in an awful lot of cases, it is actually preventable, or if not totally preventable, you can slow down the progression if you know your risk and if you follow the regimens that are recommended for you, as well as some lifestyle changes that may be recommended in order to do that. And so the purpose of this coalition is to bring together people from across the spectrum, patients themselves, other voluntary health organizations, charitable organizations like the American Kidney Fund, industry partners, people who are interested and who are vested in trying to deal with this disease. So that's what the coalition is all about. And it is to develop a map for what all of us from our different perspectives can do to address this issue of the disease and of its disproportionate impact on people of color. Some of the other things that we've already done is we started a website specifically on kidney care for all, where we will continue to develop that and include information about the disease, about its impact, and about what people can do about it. It's very important, I think, that people understand that you can be empowered to do something about this disease. You don't have to be silent. You don't have to be silent. You don't have to be a victim. We just a few months ago worked with Home Dialyzers United, and we did a webinar on home dialysis because there is a gap between people of color and others with regard to the use of home dialysis care, which, if it is clinically appropriate for you, can really begin to resolve some of the issues of having to spend so much time on dialysis and can have better clinical outcomes. Again, if it's appropriate for you, that's something you have to determine with your doctor. But we use that webinar to talk about what are the advantages, what are the lifestyle implications of this. What are the ways that you can achieve your goals and be on dialysis? We also are working with industry partners in terms of clinical trials. We have another section on our website to provide concrete information to people that they can use to make a determination on whether clinical trials are appropriate for them. And also we use that to dispel some of the myths that sometimes make people hesitant to be part of clinical trials. And we will continue to develop all of these vehicles as a way of getting out information, as a way of connecting with various organizations around the country, and very importantly, as a way of connecting directly with patients.
And if I may add to what Laverne just said, I think coalition building honestly has been one of the most incredible things that has come out of the COVID-19 pandemic. In our state here, we have connected with a lot of the nonprofits who are also very interested in expanding access to care to disadvantaged populations. And we've had just tremendous impact by, building this collaboration. We've pushed some legislation forward. We've made sub-regulatory and regulatory changes. And so we've seen sort of large groups of people really work together to expand access to care. And something interesting that's also happened this past year is that in building this coalition, we've connected more on what the social determinant of health priorities are for the communities. A big one was education. And so this upcoming year, we're actually statewide launching several pipeline programs that will be connected to bachelor's programs and graduate healthcare degree programs to really sort of close the academic achievement gap and increase diversity in our entire health and healthcare workforce. And so really sort of working as a coalition to create some real change. And I would say a second thing that our group has done just in the past year, especially with respect to kidney failure, is disseminating a lot of the information that was helpful for us in Colorado in expanding access to care for undocumented immigrants with kidney failure. We've seen an increase in the number of states. Colorado expanded care in 2019, and I think we were the 12th state actually to expand access to care, and now we're at 20 states. And so really sort of seeing change. I think people realize that it's important to keep undocumented immigrant patients receiving good care, but also outside of the emergency department, especially during the pandemic when ED resources were, quite tight. And so policy change and coalition building, we've seen a lot of.
Elaine, you're part of the AKF Health Equity Coalition, correct? I wonder if you could talk a little bit about it from the clinician perspective, but also just some of the work going on in your practice in the Bay Area and so forth.
Yeah, sure. I've been fortunate to be part of the AKF Health Equity Coalition. And certainly I think its main pillars are just so important in terms of improving access to home dialysis and kidney transplantation. Some of the tools that have come out of the AKF Health Equity Coalition were based on the work that the AKF did in qualitative interviews with providers as well as patients, which I think is just so informative, especially the patient perspective, because oftentimes the manner in which they describe their barriers and, for example, getting onto the wait list and what strategies might be helpful to them is not always what I think we as clinicians think might potentially be helpful. And their strategies often bring innovative ideas as to how to improve the patient experience, but also address the inequities that we know are present in access to kidney transplantation. And so I think that toolkit is certainly in development and will be very useful to patients. The other things that I have been honored to participate in include educational seminars. I think the AKF has really been leading efforts in providing more education about kidney disease, increasing awareness, education about newer therapies that are now available that patients may not have heard about, but they certainly should consider if they do have kidney disease, and how diet and behavioral choices may influence the progression of kidney disease. And so I think these are all great tools that will become available widely as we further develop the toolkits for patients and providers to really help disseminate information and also empower patients to really advocate for access to the wait list and recognize their the options that are available to them when their kidneys fail.
I'd love to talk, it was mentioned, clinical trials were mentioned a few minutes ago. Deidre, maybe we could start with you. How do we broaden participation in these trials? What can you tell us here? And is there meaningful action or momentum happening on that front?
Yeah, thanks for that. So in terms of thinking about clinical trials, and they're so important, I think, for helping us answer important questions about sort of how can we mitigate these health inequities that I think all of us certainly care about and want to do something about. And so I think a number of different approaches that are being taken more recently that I'm pretty excited about. I think one of them is that we're seeing greater early engagement with the populations that are potentially going to be quite affected by the therapies that are being tested. So including some of the same groups that we're talking about today, racial or ethnic minoritized communities, people who have low incomes or maybe limited access to healthcare. Increasingly, there are more both kind of institutionally sort of based, sort of academically based research teams that are engaging with these populations early in their design of studies, as well as a number of industry study sponsors who are engaging. And I think it's so important that the engagement not just be, we've designed this study and tell us what you think about it, but it needs to be let us co-design this together so that it's sort of meaningfully focused on the things that these populations care about the most. I'll tell you, we've through our work have actually altered our plans altogether in terms of what's going to be the intervention group versus what's going to be the control group through our work with our community partners. And so I think that's a really important piece. And I'm quite excited as well now that we have some newer therapies in terms of our ability to be able to slow the progression of chronic kidney disease that we're seeing, and I think we need to see more of this, but we're seeing an increasing number of investigators interested in implementation science sort of approaches where we're testing ways to actually get those therapies to the people who are probably most likely to benefit the most, because we know they have the greatest risk of progression of kidney disease. And so engaging them in those types of trials are going to be particularly important, as well as, again, as we try to answer some questions, not so much about, I think we're getting more answers about what can work, but also we need to understand how to sort of get it done in health systems or in communities. And so I think it's a pretty exciting time. While we've talked a lot about profound disparities, I think it's a pretty exciting time for our field as far as thinking about what can be done for people who are affected by kidney disease.
Deidre, I think you're exactly right about that. And it's also an exciting time because many of the pharma and biopharma companies are really focused on the importance of inclusiveness in their clinical trials and trying to figure out how to reach populations that are most effective. So there is more of an open door, I think, than there may have historically been. And that's a role that I think many charitable organizations, patient advocacy organizations can play. Our first step was making sure that we provide people with objective information, because it absolutely has to be a patient decision, but it needs to be an informed decision. And so that's why we, for the last several years, have been continuously upgrading our website and the kind of information that we provide. But we also have partnered with a number of biopharma companies on specific trials. And we want to provide that information to patients so that they can take the objective information that we've got on the website about clinical trials and then know which ones they may have an interest in, and they can compare and they have questions that they can ask to see, is this trial appropriate to them? And we want to connect those things, not only in terms of, as you say, in terms of getting people to participate in the actual trial, but getting the patient voice in the design of the trial and making sure that in the protocols for the trial, that it's done in a patient-friendly way. The American Kidney Fund in particular serves a lot of low-income patients because our programs are often geared toward providing assistance to those who cannot cover the full cost of their own care. And we need to be really careful in that to make sure that just in terms of how patients are going to participate in this trial, whether it's doing the workday or whether there's some of it that can be done telephonically or otherwise, so that patients don't have to take time off from work or have the expense and the time to go a place to the extent that the trial can come to them. And also just how the trial is, the language that's used in the trial, to make sure that it is not only something that is in the language of the people that you're trying to involve in that trial, but that it's culturally relevant language. So all of those are things, and I think that charitable organizations like AKF can play a very important role in connecting the trials and the patients in a very appropriate and informed way.
Lily, I wonder if you could talk a little bit about just access to care, dialysis in general. What's the situation there? I'm sure it's difficult to generalize, but if you look at certain groups and what specific efforts or programs are being done to address gaps in access, costs, and so forth.
Yes, of course. So many folks know that as Director of Immigrant Care, a lot of my research and advocacy work has really focused on increasing access to care for undocumented U.S. residents. There are anywhere between 6,000 to 9,000 individuals with kidney failure throughout the country. And as I mentioned earlier, about only 20 states right now provide access to standard dialysis. And so we've really worked to sort of disseminate the policy steps that folks can take in other states to expand access to care for this community. But also, regular individuals, not regular, but documented and undocumented Latinos in Colorado. Some of the work that we've done has focused on providing Latinos receiving in-center dialysis with the social resources that they need to thrive. Many people throughout the country, especially with kidney failure, face a disproportionate burden of social challenges. And so, once they have kidney failure, it becomes very difficult for them to work and be part of life. And so really sort of providing them with the social needs that they have helps them improve their own health. One of the studies we recently completed included a community health worker that provided dialysis patients with all the social resources that they needed to thrive. And we actually saw an improvement in patient activation, which was very exciting. It really meant that patients were engaged in taking care of themselves and perhaps seeing their clinician more often and accessing clinical care. And so, I think my experience really speaks more to the Latino and undocumented immigrant community and access to care issues. So I'm excited to hear what others have to say.
Want to add on?
I could tell you that one of our most important programs really is the health insurance premium program. It allows us to provide assistance to help people pay health insurance premiums when they are in kidney failure, when they are on dialysis, or if they've had a transplant. And the last year we assisted over 60,000 people, making sure that they could get access to care. We also have advocacy efforts around the country to make sure that people also have access to supplemental care. So that they can, that allows them to cover not only the basic cost, but also to help to reduce their out-of-pocket costs. And very importantly, they have to have that insurance in order to qualify to be on a transplant list. So we're doing many of the same trying to reach many of the same populations that you are, with financial assistance and with support to make sure that they can get the care that they need.
Elaine, I'd love to pitch it to you and talk about transplant advances and how to ensure equity there. That's another facet of the whole sort of puzzle that is important. Could you shed a little light on that for us?
I think historically we know that certain groups have been disadvantaged in terms of transplant access. That includes people of color, women, older individuals. We've observed disparities in access to the wait list, to living donor transplantation, and to deceased donor transplantation. I think there have been efforts in trying to improve inequities in access to kidney transplantation, starting first in 2014, when multiple changes were implemented in a kidney allocation system and waitlisting rules, such that patients on dialysis would have their wait time backdated to the date when they started dialysis rather than whenever they were actually referred and evaluated by a transplant center. That certainly has improved some of the inequities that we had traditionally observed, particularly racial inequities in access to wait time. I think more recently, certainly with the publication of the race-free estimating GFR estimating equations, there have also been additional changes that have been implemented nationally, including the requirement last year that patients who are being waitlisted, that we use a race-free equation in order to assess eligibility for waitlisting. And then subsequent to that, certainly there was a decision that all transplant centers should be reviewing their patient lists and looking at which and assessing whether or not Black patients who were traditionally disadvantaged because of the use of a race-inclusive term when we were estimating their kidney function and assessing eligibility for waitlists, that be reviewed by the transplant center, and that the transplant center reach out to these patients to inform them of changes to their wait time through the use of a race-free equation. So I think that there has been efforts to try to address some of the inequities that were introduced through the use of a race-inclusive equation to estimate kidney function, and there have been some changes there.
We have an audience question. Someone in our audience asks, Vermint says, co-design with patients is important, but how can we remove barriers for patient participation? Childcare, no time off from hourly work, transportation, et cetera. I wonder if someone could weigh in on that. Deirdre, maybe that links back to something we talked about earlier.
Yeah, thanks. And sort of, I think it's a really important question. I think this is another place where I think we can learn a lot from what we've adapted to in the pandemic. And so in thinking about telemedicine and sort of how we've been able to do so many things remotely, I think there is a great need for considering research study designs that allow for a more remote collection of data, or collection of data at a time that is a time and place that's convenient for broader groups of people. And I think we're seeing more of that. We're seeing there even sort of support and encouragement for that, even through some of the studies and programs funded through the National Institutes of Health, for example. And so I agree that is definitely something that should be focused upon. That type of need tends to come out when there's early engagement with the populations that are the focus of these research studies, or that are at least going to be highly represented in those studies. Generally, if asked, such people will say, "Hey, would love to be in your study, but that's all the way on the other side of town from where I live," or I'm not sure people would have the sort of ability to get there, or it's not convenient. And I think those types of design aspects can be worked out if the research investigators know that that's based upon what they've learned from engaging early on with the populations of interest. If they know that, then usually there is a way to do that. And I think we're seeing, I shared with you the dietary intervention that we had. We started off having participants come and pick up the food for it on a weekly basis, and then quickly pivoted to actually having that food delivered to their homes, for some of the same considerations, because transportation, of course, was a barrier for many people. So I do think there's a way, and increasingly there seems to be more interest in sorting those things out.
Any others want to mention other facets of sort of the social determinants of health, or things that are working in your communities or with AKF partners? Well, let's talk a little bit about policy then, because again, this is something we've discussed already, but it's interrelated to a lot of this. Are there policy solutions at the state, federal, local levels that would help with chronic kidney disease? We've got a few audience members who've raised questions about, a bill in Florida that would require the check of immigration status of patients, for example, some other sort of state-by-state policy concerns and considerations. I'd love to just spend a few moments talking and unpacking that a little bit. Are there lessons from particular states, from places that you've worked with, that could provide a roadmap for others? LaVarn, maybe we could start with you. And I know the AKF has kind of a policy or a donor protection report card that's just one of those resources that might be helpful on this front.
I want to address that, but I want to address the first part of your statement and the Florida situation. Our focus and our mission is around helping people who have kidney disease. And so we're not looking at categorizing those people in terms of their immigration status or anything else. We're looking at whether or not they have kidney disease or are at risk for that, and whether we have programs and activities that can help them in dealing with that. So our program is fully open to those who are looking for ways of dealing with the disease without regard to various kinds of status. And then the second part of your question, I must admit, I kind of got it lost. If you can repeat that.
Of course, yeah. I think I'd love to explore kind of policy and advocacy. Are there things that AKF is doing, and for the broader group, are there things that you've seen or you'd recommend to some of the clinicians, the advocates, the public health leaders in our audience?
Yeah, I'd really like to start with one example that you mentioned, our living organ donor report card. We started these efforts about 4 years ago. At the state level, we started working with legislators and other groups at the state level who had an interest in encouraging living organ donor protection. The issue there, in case the audience may not be aware of it, is that number one, getting a transplant if you're in kidney failure, and if you can find one, and if medically it's appropriate for you, can be the absolutely best solution from so many perspectives, of course, physically, but also economically and socially, to allow you to go on with your life. The problem is that there's a really scarcity of organs. We've got over 100,000 people on the organ transplant list, the vast majority of whom are waiting for kidneys. And last year, there were about 25,000 kidney transplants. So we just don't have enough organs to go around. Some individuals, for very humane reasons, choose to say, I want to give an organ. And one of the most awful things that can happen is that a person in some places can contribute an organ, and then that person will find him or herself penalized in terms of being able to get various kinds of insurance, or not being able to take time off from work, or not having help with the costs that they will bear as a result of doing something that's good for somebody else. So we started working at the state level to get legislation passed that would protect people who are giving organs to other people who need them, that would protect them from insurance discrimination, that would allow in some cases for them to have time off, whether in a public work setting or a private work setting. There's even in the state of New York where grants are provided to people now who are wanting to give organs. And over the last 3 or 4 years, we've seen almost 30 states pass legislation that encourages people and protects people who want to give organs. We started the report card as a way of trying to help people understand both the challenge and the progress that we're making in dealing with this challenge. And when we first did the report card 3 years ago, the average grade for states around the country was a D. Over the last 3 years, that grade has come up to a C. But we still have 17 states that are Ds or Fs. And so we will continue to work at the state level to do that. But very importantly, just in the last week, the Living Organ Donor Protection Act, a federal act out of the US Congress, was again introduced. It's been introduced a number of times, but we and many other charitable groups are really pushing hard to try to get that legislation passed so that you don't have this patchwork of different rules in different states, but you've got one set of standards and rules and protections for the country overall. And we're really excited about that. And we ask others to join with us in supporting that legislation.
Lily, could you talk a little bit more about emergency Medicaid and some of your own policy advocacy work in Colorado?
Yeah, absolutely. Just wanted to take a step back and mention that just a handful of years ago, Colorado codified a kidney disease committee. And separate from this kidney disease committee, we also passed a bill that mandates that healthcare systems collect demographic information and social determinants of health information across the state. And so what this has really done is really helped us begin to understand where there are problems, right? So where can we sort of eliminate structural racism in a way that's targeted at the communities that are facing maybe a high prevalence of kidney disease. I want to also just go back to what Laverne said earlier about coalition building. Our state, as I mentioned, we used to have something like 200 or 180 to 200 undocumented residents that had kidney failure that would come to our hospital once a week when critically ill to receive emergency dialysis. We did a lot of coalition building, and after the research, after we changed this coalition continued to create change. And so the two bills that I mentioned that provide data, the Kidney Disease Committee, the coalition building around all this has led to lots of really great legislation in our state. We passed, for example, Cover All Coloradans. That's HB 1289. And this one was because people kept saying, we have this high number of individuals with kidney failure. How can we prevent kidney disease? How can we get people seen sooner? And so through coalition building and organizing, we've essentially passed this bill that now expands full scope Medicaid to undocumented children. And right now for women postpartum for 12 months, but we're hoping to make this even bigger, right? And we've also passed another bill called the Health Insurance Affordability Enterprise. This provides 10,000 people in our state that don't have health insurance with free health insurance off the exchange. And so really trying to sort of work towards bills and, codify ways to expand access to care so that we are starting earlier with education and preventing kidney disease in our communities, but really sort of guided by the data in our state.
What about, workforce and staffing? That has emerged as a major concern across the healthcare industry, especially in the wake of the last few years of battling the pandemic. What do you see in nephrology or, among the other professional specialists that you all work with at your own institutions? Is that a concern here? Or are there any insights or solutions you could kind of point to that might be helpful?
I could weigh in a bit here. I think there are a couple of places where I think there are a need in sort of the kidney care space. Certainly, we're always recruiting for more nephrologists, and I think some of the excitement that we're seeing in our field in terms of these newer therapies, we're hopeful is going to attract some people coming out of their residency in pediatrics or internal medicine who may be interested in pursuing a career in nephrology. So I think that's one space We've also seen some real challenges in terms of the care of people with kidney failure, particularly dialysis patients, and the staff that take care of them. So thinking here about dialysis technicians and nurses who care for those patients, and have seen that some of the, particularly some of the larger dialysis organizations who have had to try to find new ways to sort of cover the needs. When we think about that patients who are treated on dialysis, at least in a center, are coming in 3 times a week, and that there's a great need for staffing for that. And so I think that's going to be a continued area of sort of focus of figuring out how can we better incentivize people to one, go into that area of work where they're greatly needed, but also to make sure that we support and appreciate those that are there, so that we can retain them. So I think that's definitely an ongoing challenge, as well as an invitation to maybe people who are tuned in that this is definitely an area of great need.
I would just add to that I think it's important that we continue to expand the diversity of our workforce, people of different backgrounds, perspectives, and experiences. And to that end, I think that the National Institute of Health certainly is changing the way that it's supporting some of our training programs for our future nephrology trainees, and trying to build interest from a much earlier time in people's careers, and guiding people to both pursue nephrology, but also pursue research careers in nephrology, which I think is also critically important, because there's so much that we still need to learn in order to address health inequities within chronic kidney disease, and really inspiring the next generation to be well prepared to address these inequities and conduct research so that we can improve care, I think is also really important.
We've got less than 10 minutes left. The time is flying by, but I want to make sure to make time for some audience questions and a couple more questions if we can squeeze them in. Laverne, question for you from someone listening in. Are there any opportunities for state health departments to become involved with the American Kidney Fund Coalition?
Yes, absolutely. I would. We often work with states and would love. Number one of the things you can do is resources on our website. Educational resources for patients. We want you to use those in your various work. But in terms of the coalition and our other activities, please come to our website and just contact us, kidneyfund.org. We would welcome you to join in these efforts. We need all hands on board.
Another audience member actually asks about some of the other kind of resources and greater education for the public. This person writes, as a Medicare case manager for an insurance company, I deal with members who often are diagnosed with chronic kidney disease, but who have little knowledge or education on the disease. They don't know their stage. They don't know how much, they don't know much about how it works or have proper education on how to prevent it from getting worse. In addition to some of the ideas that you've already shared, can you speak to the disconnect here about where people are getting little to no education in the doctor's office, or what some of the best practices or best ways that they can get some of that knowledge out there?
Yeah, maybe I'll chime in a bit, and I see Laverne unmuting, so I think she may have a thought too. So yeah, I would start by saying that one of the key challenges is most people are going to first have their, if they develop kidney disease, are mostly going to have it detected in the setting of a primary care visit, and often our primary care colleagues are balancing the need to educate their patients on a number of health conditions, as well as address what is acutely happening to them. And so I think fitting in what can be perceived by many, even clinicians, as being a complex disease to explain to a person can be a challenge. And so I think there are though resources available for especially for individual patients to potentially access, and I'm sure we're going to hear about some that the American Kidney Fund has. but to really help to help sort of supplement what might be learned in the setting of that primary care visit. And then I do think that the onus is on those of us who are, nephrologists or working much more specifically in the kidney space to better equip our primary care colleagues with that sort of ability to be able to communicate those findings to their patients. I'm excited about this is the first time in my lifetime that I can turn on the television and hear chronic kidney disease mentioned due to some newer therapies. So I think we're only going to see increasing numbers of people who are going to have questions. What do my kidney numbers look like when they go to see their various clinicians? And so I think you really now is the time to kind of make sure we have the information that's in an understandable, sort of easy to communicate fashion at the hands of our colleagues who are providing most of that initial or sort of frontline care for people with kidney disease.
Thanks so much, Deidre, for a terrific lead in. Yes, we education. Please do use our website, both for professionals as well as for patients. Again, kidneyfund.org. Information on the basics of chronic kidney disease and related diseases. Also, we have webinars. We just started a new webinar focused on primary care providers to help them in their conversations with patients for early detection, early prevention, and those conversations that occur. And that we've had great pickup in terms of participation in that. And we actually just started one also for nephrologists, because we're very focused also on making sure that once patients know that they have kidney disease or they are in kidney failure, that they understand as much as is available about what's causing it. The major causes are high blood pressure and diabetes, but there are other causes, some of which are genetic causes. And having a patient understand that and having the doctor look at it from that perspective can make a lot of difference in achieving a positive outcome. One of the saddest things is a patient is able to get that really valuable transplant or several, and the transplant fails because there's another condition going on that the patient didn't know about, and perhaps even the provider didn't know about. And so getting that complete conversation, not only on the fact that you have kidney disease or kidney failure, but what's causing it, so that you get the best possible treatment. And we've got a wealth of information on the website and continuing to develop that, as well as continuing our courses for patients. We have a patient network of 20,000 patients. And I can tell you that that's a very valuable educational tool, whether it's the conversations that patients have among themselves on social media, or examples of things that we do, like next week, we will be bringing patients into Washington, D.C. to talk to their members of Congress, but that also will give them the opportunity to get to know other people who are dealing with the same disease challenges and to develop relationships with that. So there are lots of opportunities, and we are very happy that we're able to facilitate so many of those.
I want to squeeze one more question in before I turn to a final comment from each of you. Elaine, this is a question somebody in our audience asks about data. What data does the field need to better understand health disparities in general, across the kind of spectrum of diagnosis, treatment, and so forth?
Yeah, I think we need several types of data. One is what we're already moving towards, which is really hearing more from patients, hearing their voices, their experiences, how to address some of these inequities. But I think the other area where we really need more data is really on social determinants of health. Most of the data that we do have nationally, where we have large numbers of patients with either chronic kidney disease or end-stage kidney disease or transplant registries, have really not systematically collected detailed granular data about social determinants of health. And so it makes it more challenging for us to know what are the social determinants of health that really influence health outcomes, and how do we address those in order to improve the inequities that we're actually observing. And so these include factors such as health literacy, health numeracy, access to health technology, access to transportation, jobs, security. These are such important factors that I think we just don't really have a great grasp on, because traditionally our data systems and registries and cohorts have not necessarily collected all of this. But I think there are certainly opportunities for institutions to do so. Certainly at our institution, there are now tools that we can implement when patients come in to screen for their social determinants of health. And that can really allow us as providers, I think, to tailor the care to the patient's sort of circumstances, so that they can access care and get the health care that they need.
We're hitting our time, but I want to just allow everyone one more opportunity for a final comment, a call to action, or something that either hasn't been shared or that you'd want to underscore. LaVarn, maybe we could start with you.
Yes, I'll try to be quick. The fact that we're having this conversation and
that we say people don't know about kidney disease or don't know its importance is really very telling, because kidney disease is the fastest growing non-contagious disease in this country. It has an effect certainly on the lives of people who have to deal with it, has economic and policy consequences. We really want to see kidney disease as a top of mind issue, and we want to work together to address those issues overall. Really, really important.
Elaine, how about you?
I think education, advocacy, both on the patient individual level, but also on a community level, is just so important. And I'm so glad we're having these conversations and excited for the future.
And Deirdre?
Sure, I'll just pile on. Yeah, I'll say the same. Excited to be having the conversation. Have great hope for what is already starting to come, as far as this focus, particularly on equity, as well as I mentioned, these new therapies. And I would encourage really people who are in. I know we all have various different spheres of influence around a lot of the topics that we've talked about today, whether it's policy or as a clinician or as a caregiver, to really to kind of join in with us and actually get the word out about these issues and sort of remain steadfast in our advocacy. Yeah, and thank you for today.
Thank you. And Lily.
And I'll be super short. I echo what everyone else has said, and just thrilled that you've highlighted kidney disease today. I hope that we continue to see folks highlight kidney disease. And I guess one call to action is to continue to build coalitions and work towards change in partnership with patients and community organizations, because change is possible. We just have to get out there and do it and persist.
That's a great note, I think, to close out on. I want to thank Dr. Lilia Cervantes, Dr. Elaine Koo, LaVarn Burton, and Dr. Deirdre Cruz for making the time. Thanks to all of you in our audience who joined us and for those good questions. Visit usnews.com/events for a video of this session and for more information about some upcoming sessions we have coming. Thank you all so much.
Thank you.